Hello. Last topic was more of a basic head injury and neuro exam. This one I want to go into more of a diagnosis, quick management, and then next one I'm going to use the ICP time. I'm sorry I changed out the order, but I thought if we go in order it's easier as to continue to the next step. Okay, the initial one we're going to talk about again Glasgow Coma Scale, and again this is very basic. It's every EMT, every medical person associated with taking care of trauma patients is familiar with this. It's something that last time they asked me what's the easiest way to remember it, there isn't. You just have to memorize it. Why? Because it's the easiest way for us to communicate with other medical staff, anybody that has to do with patient care, because there is less variability than, you're trying to tell me how this patient is doing, etc. And there is variability. It really depends on who is doing the interpretation. And I'll go into, actually I have a couple more slides, the next topic, to try and go over some diagrams that I have about extensor and the cerebral posturing and those things, because that's where people get confused the most. And again, the Glasgow Coma Scale was intended to ease your communication between the medical staff, and it also has a prognostic factor. The better GCS scores have better outcomes, and it all depends on, again, on how the patient came in. And we have to remember, not everybody with a low GCS score means that they're brain dead. And we have to go back and I'll go into what they're doing, the assessments we have to do. Was the patient on drugs, alcohol? Was the patient intubated? Or did we do something to the patient? That's why the patient is a GCS of 3. So again, the Coma Glasgow Scale is 3 parts: the eye opening, the verbal response, the motor response. And here we talk about spontaneous eye opening. Patient opens their eyes, moves, looks around, that's a 4. If patient opens their eyes you ask them their name, that's a 3. To pain, painful stimuli. And depending on where you guys train, when I started training, they used to do nipple twist to wake up patients. Don't do that. If you want to wake up someone, do a sternal rub, nail bed pressure. Okay? Why? Because there's always a possibility a family says, why are there bruising there? What have you been doing or something? So it's more of, do you really want to do that? No. But that's the way they used to do. I don't know if anybody remembers doing that. It's like, no, there's better ways to do this. Then the next part of the GCS is the verbal response. You, again, ask a couple questions. You know your name, you know where you're at. I like asking, fortunately here, there's a board in front of their bed. It says today's date and everything. But I like standing in front of it so they can just look at it. I like to ask them where they're at, location, time, why you're in the hospital. And I always put in like who's the president or something, just to try to make sure, because there's a lot of demented people who can keep a conversation and you think they're fine, but then you start asking a little bit more, they're just pleasantly confused. But they can keep a conversation, talk about their grandchildren. They say, oh, you look like my granddaughter, blah, blah, blah. And they can take a full-hour conversation and you don't realize they're not there. You ask them, who's the president? Where do you live? Things like that, you have to be more specific. That's why in the verbal response, you have to make sure that there aren't confused conversation. This is the demented person. They can talk everything. They can tell you anything they remember, but they can't remember current events, things that are currently happening, or why they're even in the hospital. Sometimes they even say, I'm still at home. I'm in, where they came from. The next one, the verbal response, inappropriate. Someone starts screaming something that they're, tell the mom to turn off the light, something inappropriate conversation. And then sounds, moaning, groaning, that would be a number 2. And then a 1 would be for nothing, no verbal response. And here we can substitute the verbal with a T. You can write eye-opening and motor response and say a GCS of 11T. The T is for a patient having an ET tube, a patient intubated.
So this is sort of where I come into the verbal response between an oriented and confused. Okay, so if you're looking at a patient's coma score, it seems like a slightly demented person should get an oriented. Because that's sort of their baseline. Yes. This isn't a neurological damage other than progressive something. So I'm always vacillate on that one. What is the appropriate
in a Coma Glasgow scale, they always want to get the best score.
Right.
But it's you want to be the most accurate also, because
It seems like there should be like an oriented and a, or confused and a
I
half
know,
or
but
something.
at the same time, if you say, well, I want to, he's demented, but that's his baseline, but that tells me that he's a GCS of 14. That tells me there's something wrong with him. So in a quick, sentence, you're saying patient's GCS score is 14. I can say, oh, there's something wrong. And I don't know what it is, but you're doing the phone call at the middle of the night to tell me there's something wrong with the patient. But if you say he's GCS 14 at his baseline dementia, you're justifying the 14 and why it's that. So you should be accurate to the point of the description. And again, these scales can vary depending on who's interpreting.
Yeah.
I agree. But the GCS scale of 14 and 15 doesn't really make a difference. We're talking about 8s, 7s, 6s. That depends on what I need to do for a patient. The patient has to be intubated. We have to do ICP monitoring. He has to be in the unit. Versus someone who is sundowning, older elderly patient who gets confused at night. So yes, you want to be accurate, but a little, 14, 13, won't make a difference unless there's a big change from he walked in a 15 and now he's a 12 and now he becomes a 9. Then you want to be able to follow that. Okay. Then best motor response. This one's difficult for spinal cord injury patients. Patients paralyzed. You have them move their tongue, stick out their tongue. Tell them, stick out your tongue, move your eyes, and then you can get a motor response. It doesn't mean that, show me 2 fingers. If you're paralyzed, you can't do it, but you can get other responses. I like using the tongue, stick out your tongue if I know someone's intubated, paralyzed, and I can tell that they understand and they're following commands, and they're doing a motor response. And then localizing to pain. This one in spinal cord injury patients, you can't really do it, but you can say they're following commands. Localizing to patient, you have the patient, and always in a gurney or and you put the patient's hands, and you put them kind of over their belly. That's their midline, okay? And then what you do is you sternal rub. If the patient comes up, localizes, grabs your hand, that's very purposeful. He is really localizing your hand. And then we go to the flexion and extension. The flexion abnormal and extension abnormal. And here, they talk about flexion abnormal, and this is really confusing when people say, is decerebrated corticate? Forget those 2 words. Don't say abnormal flexing or extension. Forget this decerebrated corticate. It confuses people. People won't. And I've got another slide for next presentation talking about specifically what part of the brain gives you each response. But when someone says, oh, he's decerebrating, whoa, decorticating, just flexing or extending. There's nothing else. And flexing means you put the hands up, you do a sternal rub, and they do flexion. You do a sternal rub, you do extension. Okay, so that's what it means. And then, again, no motor response. Patient can be paralyzed, they can be flaccid. Correct. And then here I'm going back to the patient's intubated. You can go to a 11T, and there's ways to, if you want to be smart ass, you can always say the patient's a GCS 13T. Patients can mouth the words. Get this out of my mouth. And you can see that. You can see them mouth words. But yes, the best T would be an 11T. Okay. And again, the concern is more of a GCS of 8. GCS of 7. Why? Because a lot of the managements depend on the lower GCS scores. 12, 13, 14 is a concern, but the ones you really want to be on top of are the lower, the 7, the 8s, the 9s. I'll talk about herniation syndromes and how to recognize these. Most of the times we diagnose this by CT, because everybody gets a CT in the emergency department. Everybody gets a CVC, a CT, and Foley catheter. But what does a herniation syndrome mean? Herniation means displacement. We've got a good presentation here. Displacement of the brain. For instance, let's see if this works. Tonsillar herniation. The cerebellum has the lower part that they're called cerebellar tonsils. If there is pressure on the brain pushing down, the cerebellar tonsils are the first ones who are going to start coming down. There's also other called uncal herniation. And here we see, it's temporal lobe, uncal herniation. The uncus is part of the brain, but what happens is if there is a temporal lobe hematoma here, it's pushing and it's putting pressure, and it's the temporal lobe causing the herniation. And this is the tentorium. The tentorium is a fold where the cerebellum is separated from the brain. And what happens there, that the brain starts trying to find, and think of the brain as squeezing a sausage. You squeeze a sausage, there's only one place it go out, the ends. Barely does it go out through the sides. I'm talking of the old casing sausages. Okay, if you squeeze them, they never come out where there's resistance. Always the path of least resistance. And the path of least resistance is where the brain is rigid. This is strong, and this is soft. This is strong, and the brain is soft. The brain is the consistency of jello. And so if you're having pressure on it, it will just displace the brain, and it'll try to find the path of least resistance. This is a subfalcine herniation. This is the falx cerebri. This is a tissue, connective tissue that separates the hemispheres. So if you've got pressure on one side, the brain tries to find a place to go. It goes under this layer, the falx, and it herniates under. Okay? Uncal herniation, this is basically the most common, and this is where the brain is displaced, putting pressure onto the brainstem, and it's putting pressure onto the temporal lobe over the tentorial edge, like I showed you right here. And this is an anatomic pathology specimen. This is the brain looking at from the bottom. This is the midbrain. This is the temporal lobe. This is the temporal lobe. This would be the frontal lobes. This is the optic chiasm. And so what's happening here, the tentorium is rigid, but the brain is trying to squeeze under there. And that's why there's an indentation here. And uncal herniation would be putting pressure on the midbrain. Okay. Early signs, pupillary dilatation. Everybody says, oh, blown pupil. Blown pupil can be caused from many things, like I talked last time. Blown pupil, again, 10 to 20% of the population can have anisocoria, abnormal sized pupils. One pupil can be a 3, the other pupil can be a 4. Pupillary dilatation means a large pupil. And like I said last time, it doesn't matter if you're saying it's a 2.5, 3 millimeter pupil. No, it's a large pupil or a pinpoint pupil. The middle pupil, you can say it's a 3, 4, but if you're concerned about pupillary dilatation, you will see a very large pupil. Okay, that's an early sign. And what it is, it's putting pressure on the third nerve, and it's causing pupillary dilatation. Late signs say complete pupillary third nerve palsy. And why I say this, because if there's a little bit of pressure on the third nerve, the rest of the third nerve, the extraocular muscles keep working, but the pupillary response is the one that's gone. But when there's a lot of pressure on the third nerve, patients can't move their eyes anymore. Okay, the ipsilateral eye. Loss of consciousness. Again, patients are unresponsive. They came in, they're a baseball player, softball hit them on the head, they had lucid interval, they were fine, and now they passed out. This is a late sign. Another thing that we can see here is contralateral hemiplegia. And hemiplegia, as the brain functions, my right hemisphere controls my left side of my body. And the same thing, the left hemisphere controls the right side of my body. And you have a contralateral hemiplegia, because you're putting pressure on one side, depending on the location, part of your body wouldn't move on the contralateral side. But there's also something here, it kind of says, well, now I'm saying ipsilateral. Well, there's something called Kernohan's notch. And this means that by putting pressure on one side, the other side, if I'm putting pressure on this side, the other side can start to get pinched by the other side. So that's why you can have an ipsilateral hemiplegia. But again, these are signs that you would say, well, back then before CT, people would go exploratory burrow holes and say, oops, wrong side, because now it's putting pressure on the other side. But this is why, okay? And then flaccid paralysis, so that means the patient's probably not going to survive. Tonsillar herniation, like I said, it's downward displacement of the tonsils, the left magnum, and these patients usually just die. They take away the respiratory drive, that's it. And this is something that, if you hear of an ER doctor, someone comes in, they're confused, they're baseball or anything, and they're going to do a LP without making sure in the brain there's not an issue, they're going to cause the downward herniation. And why? It's the pressure inside the brain is built up. And if you remove spinal fluid, you have a column of water. If you pull out pressure here, it will just push down.
Like a vacuum.
And then the patient will not respond again. And here's an MRI, and here